One is able to use the magic biomarkers or MAP in guiding therapy for patients with steroid-resistant acute GVHD. We have looked in our database, and approximately 35% of patients require second-line therapy because they have either a partial response that isn't very complete or they have not responded. Now, we have looked in our database at patients who are receiving second-line therapy, and in 167 patients, we were able to compare those patients who received ruxolitinib with those patients who received other therapies that were the best available therapy at the time. Now, these patients were not guided by biomarkers. It was just what the clinician thought was best at the time. But now we have some biomarker results on those patients, and we have published these data in Blood Advances in 2024. And the key finding in this study is that a high MAP, or Ann Arbor 3 serum biomarkers, predicts a very poor outcome in patients with steroid-resistant GVHD, even when they received ruxolitinib. So what you see on the left are the non-relapse mortality curves, and with a high MAP, which is Ann Arbor 3, the mortality rises to almost 80% at 24 months. And the overall survival is dismal at less than 20%. And this includes patients who received ruxolitinib. So we concluded that ruxolitinib was not effective when the MAP is high or Ann Arbor 3. So that kind of patient needs probably 3 lines of therapy and not just ruxolitinib and steroids. So if you were to send a serum sample and clinical symptom staging on a patient who's got steroid-resistant GVHD, in this particular patient, they had stage 2 skin, not uncommon, less than 50%. Their bilirubin was 2.4, so that's stage 1 liver. They did not have any upper GI, but the stage of their lower GI with about 700 cc's of diarrhea was a stage 1. This is still Manhattan risk high, but when the biomarkers were tested, they were also high. So that makes it a magic composite score of 3 with only a 30% response after day 28 and a 52% non-relapse mortality. So this kind of patient requires, in my opinion, 3 lines of therapy to get their GVHD under control. So my recommendations for patients with steroid-resistant GVHD are as follows. If there is no response or progression at day 3, you should send a test or a retest. And if there's less than a very good partial response at day 7, you should also test or retest. When those tests come back, if the MAP is low, so Ann Arbor 1 or 2, you can use second-line therapy, which is likely to be helpful, ruxolitinib or others therapy with which you are familiar and comfortable. However, if the MAP is high or Ann Arbor 3, ruxolitinib alone will not be effective. So you need ruxolitinib plus another therapy plus steroids, and that could be a clinical trial or alpha-1 antitrypsin or Ryoncil of the mesenchymal stromal cells. Now, when the patient starts to respond, I would recommend tapering the steroids first because we know that high-dose steroids are detrimental to the regeneration of the mucosal lining that is required from an intact crypt, and steroids are damage intact crypts. So I would try to taper the steroids first. And particularly if the MAP is high, I would retest this patient approximately once a week until responses are well established. Finally, let's talk about how to use biomarkers at the time of flare. Patients who have had a reduction in their primary line of treatment, or even with 2 lines of treatment, can recur, and we know that that occurs in 20 to 25% of patients. So you have to re-escalate therapy. And at the time of flare, we've tested almost 100 patients, and we can see that in these patients, there is now only a third of them are low risk. A third are intermediate risk with a 20% non-relapse mortality, and fully a third are at high risk with a 42% non-relapse mortality after the time of flare. So for these patients, even at the beginning of therapy for flare, I would recommend a second agent. So to repeat, if Ann Arbor 1 at the time of flare, you can use low-dose steroids, 0.5 to 1 milligram per kilogram, and then a rapid taper, because these patients are likely to respond and they have low NRM. But if the patients are Ann Arbor 2 or 3, the steroid should be kept, it should be started at high dose, 2 milligrams per kilogram. Of course, there could be a clinical trial that they participate in, but they need a second agent. It could be ruxolitinib, it could be alpha-1 antitrypsin, or Ryoncil, the mesenchymal stromal cells. And then when the patient responds, I would again taper steroids first, because steroids are so detrimental to regeneration of intact crypts. I would retest high-risk patients once a week. And just as a reminder, these Ann Arbor scores and MAGIC composite scores are useful whenever they are tested and can help you guide therapy. If you have any questions about these scores, I would be happy to answer them, and you can email me at james.ferrara@mssm.edu. Thank you for watching.